Welcome to Section 13 of the Renal Physiology Review. In Section 13, we'll walk through disorders of osmolality, specifically hyponatremia and hypernatremia, with an introduction to clinical presentation as well as treatment. Welcome to Section 13 of the Renal Physiology Review. In Section 13, we will go through disorders of osmolality, specifically hyponatremia, a low serum sodium concentration, and hypernatremia, an increased serum sodium concentration. We will talk about how to classify these states as well as some introduction to the treatment of each of these states. Once again, to review, osmolality is regulated primarily by the activity of ADH as well as thirst. The normal range of osmolality is between 275 to 295 milliosmoles per kilogram. The normal threshold for ADH release is approximately 280 milliosmoles per kilogram. The maximal release occurs at 295 milliosmoles per kilogram. Without ADH, we would excrete approximately 10 liters of water a day and quickly lead to volume depletion and circulatory collapse. As we've said before, ADH leads to increased permeability of the collecting duct to water, increases the presence of urea transporters, thus increasing the medullary permeability to urea, which then leads to increasing the osmolality of the medullary interstitium, which allows an environment that promotes water reabsorption. Hypoosmolar states usually manifest by low serum sodium concentration. To become hypoosmolar and to become hyponatremic, this requires free water in excess of solute. There are two major ways that this can occur. There is ingestion of fluid containing free water, or the inability of the kidneys to excrete excess water. The inability of the kidneys to excrete excess water relies on the presence of ADH in the collecting duct. With regard to classifying hypoosmolar or hyponatremic states where ADH is present in increasing water reabsorption, we classify these as either appropriate increased levels of ADH or inappropriate increased levels of ADH, depending on the status of effective circulating volume. An appropriate elevation is due to a decrease in effective circulating volume. As we said, as there is a greater than 10% fall in effective circulating volume, ADH activity is stimulated, promoting increased water reabsorption, even in the setting of low serum osmolality. Inappropriate ADH release is when there is no change in effective circulating volume. However, despite that, ADH activity is increased, promoting increased water reabsorption and further contributing to low serum osmolality. Just to review, effective circulating volume is primarily governed by the renin-angiotensin-aldosterone system, and osmolality is primarily governed by ADH and thirst. When effective circulating volume falls greater than 10%, there is crosstalk between these two systems. Angiotensin II stimulates ADH release. ADH activity will increase, leading to water reabsorption, even in the setting of a hypoosmolality. So let's walk through the clinical approach to hyponatremia. A patient presents with a plasma sodium of less than 135 milliequivalents per liter. Recall, the normal value for serum sodium is between 135 and 145 milliequivalents per liter. The two questions to ask are, what is the patient's plasma osmolality? Secondly, what is the patient's volume status? But not just the total plasma volume, but what is the patient's effective circulating volume status? In hypovolemic hyponatremia, there's increased sodium loss or decreased effective circulating volume. When this leads to the stimulation of ADH activity, this is an appropriate response. This is an adaptation to once again preserve circulating volume. The causes of hypovolemic hyponatremia are true volume depletion from GI losses such as diarrhea, vomiting, renal losses such as excess diuretics, adrenal insufficiency, or other salt wasting syndromes, or third spacing, such as the clinical scenario of severe pancreatitis where intravascular volume has third spaced into the interstitial compartment. Therefore, intravascular volume is truly fallen. Euvolemic hyponatremia is a setting where effective circulating volume is normal, yet ADH release is stimulated. The classic example is the syndrome of inappropriate ADH secretion. The pathophysiology is as follows. There is an elevation in ADH activity despite normal ECV. This can be from a variety of causes. The most classic example that appears commonly on the Step 1 exam is a patient with small cell lung cancer where a paraneoplastic syndrome is synthesis of ADH from the tumor cells. The increased ADH activity will lead to increased water reabsorption, even in the setting of decreased osmolality, as this ADH activity is ungoverned by the normal mechanisms. However, importantly, the increased water reabsorption is sensed by the body, and the renin-angiotensin-aldosterone system is still functional and is suppressed by the increase in total body volume. This leads to increased sodium losses, which then maintains euvolemia. The other common causes of SIADH are central nervous system disease, benign pulmonary diseases, non-malignancy-related pulmonary disease. Increasingly recognized is the role of medications in creating a scenario of SIADH. The medications that are the most common culprits are SSRIs, the SSRI class of antidepressants. Once again, for the Step 1 exam, the classic case is the ectopic ADH production from small cell lung cancer leading to SIADH. The clinical manifestations are hyponatremia, but normal effective circulating volume. The other clinical scenario where there is euvolemic hyponatremia is in the setting of increased free water intake. This requires massive free water intakes, greater than 10 liters a day, without concomitant sodium intake. This increased free water intake overwhelms the capacity of normal kidneys to excrete free water. Hyponatremia is then the result. The important thing to recognize, again, this will show up on the Step 1 exam, is that the difference between excess free water intake leading to hyponatremia and SIADH is the urine osmolality. In increased free water intake, the urine is appropriately dilute. The ADH axis is appropriately suppressed, and so urine osmolality will be very low, in fact maximally low, to less than 100 milliosmoles per liter. In contrast, SIADH, the urine osmolality is inappropriately elevated. ADH is active, and there is water reabsorption. In increased free water intake, ADH levels would be extremely low, appropriately so. Some of the clinical scenarios where this is seen is in psychogenic or primary polydipsia, often occurring in patients with schizophrenia or bipolar disease. Another is the scenario of beer potomania, where increased intake of dilute fluid in the form of beer is ingested without appropriate salt intake. Again, the important take-home point for the Step 1 exam is differentiating euvolemic hyponatremia from increased free water intake from SIADH. The urine osmolality is the key. In increased free water intake, the urine osmolality is appropriately low. In SIADH, it is inappropriately elevated. Finally, we go to hypervolemic hyponatremia. The hypovolemic category is misleading because effective circulating volume is decrease despite increased total body water. From the body's standpoint, this is an appropriate release of ADH and an appropriate stimulation of salt and water reabsorption. However, in reality, plasma volume is already in excess, but because of derangements in circulation, effective circulating volume is decreased. The three causes are known as the great edematous states, first being congestive heart failure, where the primary mechanism is poor cardiac output leads to decreased effective circulating volume. So even while total body volume is increased, effective circulating volume is low, which stimulates ADH release. Cirrhosis, or decompensated liver disease with ascites, leads to the stimulation of ADH through a complex circulatory dysfunction. Because of the inability to clear certain endogenous vasodilators, there's increased splanchnic and peripheral vasodilatation, which leads to decreased central, including renal blood flow. Once again, there is decreased effective circulating volume, even though total body volume is increased. Finally, in nephrotic syndrome, due to ongoing albumin losses, there is decreased plasma oncotic pressure. This leads to decreased effective circulating volume. Edema is formed because there is increased salt and water reabsorption in response. However, this does not correct the low sensed effective circulating volume, and merely contributes to the clinical pathology. Renal failure is also a manifestation of hypervolemic hyponatremia, simply because of decreased free water clearance. As there are less functional nephrons available, there will be decreased clearance of free water. The end result is hyponatremia. There is also decreased clearance of sodium, which leads to hypervolemia. In this case, in contrast to congestive heart failure or cirrhosis with ascites or nephrotic syndrome, ADH will be appropriately low. It's just that the functional nephron units available for free water clearance are just so low that, depending on water intake, hyponatremia can develop. With regard to treatment of hyponatremia, there are a few things to keep in mind. The first thing is to always treat the underlying cause if possible. The other thing is to correct hyponatremia slowly. Overly rapid correction hyponatremia can result in a syndrome called central pontine myelinolysis. Essentially, sharp changes in body osmolality cannot be compensated by the central nervous system cells. The quick changes in osmolality lead to quick changes in brain cell size, which can lead to irreversible injury. The general rule of thumb is to correct the serum sodium by no more than 0.5 milliequivalents per liter per hour, or 12 milliequivalents per liter per day. In general, we avoid the administration of hypertonic saline. The exception is the severely symptomatic patient, especially in the setting of active seizures. The final principle to remember is that the urgency of treatment should match the acuity of onset of hyponatremia. If hyponatremia onset is rapid, then patients are much more likely to develop symptoms, and rapid correction is much more appropriate. However, someone who develops slowly progressive hyponatremia, patients are less likely to develop symptoms, and therefore the avoidance of complications is the primary goal, and the slow correction should be adhered to. For hypovolemic hyponatremia, the treatment is intravascular volume resuscitation. Usually, crystalloid solution is adequate. This restores effective circulating volume to normal, which appropriately suppresses ADH, and there's resolution of hyponatremia. In euvolemic hyponatremia, the treatment is always the same, to restrict free water intake. In the setting of excess free water load, free water intake restriction by itself should correct the hyponatremia. In the setting of SIADH, free water restriction may not be enough to correct the hyponatremia, and treating the underlying cause must be attempted. one example is chemotherapy to treat small cell lung cancer, which can lead to improvement in hyponatremia. ADH inhibitors are a new class of medications that have been developed for this clinical scenario. However, how and when to use them is still not entirely clear. Hypervolemic hyponatremia, the treatment once again is focused on the underlying cause as well as free water restriction. In setting congestive heart failure, diuretics as well as vasodilators to increase cardiac function can improve the state of hyponatremia. Let's shift gears to hyperosmolar states. Hyperosmolality can be thought of as an excess of solute relative to free water. It's best thought of as a free water deficiency. Important to remember is that we normally lose approximately half a liter of free water daily. This is termed insensible losses. This is essentially free water losses through evaporation from the skin and the respiratory tract. While normally this is only approximately half a liter, in the setting of acute illness, fever, respiratory illness, people on mechanical ventilation, the insensible losses can be much higher, and these must be accounted for when encountering someone with free water deficiency and hypernatremia. One thing to also remember is that hypernatremia is a powerful stimulus for ADH release and a powerful stimulus for thirst. Therefore, to develop hypernatremia, individuals must not have free access to water. If individuals have free access to water, thirst will prevent the development of hypernatremia. However, in the extremes of age or cognitive status, the very elderly, the demented, or infants or young children who cannot govern their free water intake, they are much at higher risk to develop hypernatremia. With regard to the approach to hypernatremia, you can also use a classification based on volume status. Hypovolemic hypernatremia results from the loss of hypotonic fluid. Most commonly, this is due to extrarenal losses from diarrhea or increased insensible water loss, such as exercise, fever, mechanical ventilation, respiratory illness, etc. The other scenario is in renal losses resulting from an osmotic diuresis. The most common scenario when we encounter this is hyperglycemia from uncontrolled diabetes. Moving on to euvolemic hypernatremia. Euvolemic hypernatremia primarily occurs in the setting of diabetes insipidus. Diabetes insipidus is where there is decreased ADH activity. Thus, urine cannot be maximally concentrated, water is not reabsorbed, and there's increased free water losses. Because of the intact renin-angiotensin-aldosterone system, however, volume status is maintained. The clinical presentation is of polyuria and polydipsia. The increased free water losses lead to the polyuria. The resulting increase in serum sodium concentration still stimulates thirst, thus the polydipsia. There are two major types of diabetes insipidus. Central DI, which is a lack of ADH release from the hypothalamus, which results from central nervous system disease, or nephrogenic DI, where the kidney is insensitive to the activity of ADH. This can be due to a variety of causes: chronic kidney disease, lithium use chronically, hypercalcemia, can all lead to a nephrogenic DI. The important thing, once again, is to remember how to distinguish the two for the USMLE Step 1 exam. In central DI, simply the administration of an ADH analog will allow for water reabsorption and urinary concentration. In nephrogenic DI, however, because of the resistance to ADH, simply the administration of a vasopressin analog may not be adequate to lead to urinary concentration and water reabsorption. In treatment of hypernatremia, the same basic principles of hyponatremia treatment apply, meaning treat the underlying disorder and moving slowly in terms of the correction. In hypernatremia, the risk is cerebral edema rather than central pontine myelinolysis. With hypovolemic hypernatremia, replete the hypotonic fluid that was lost. Once again, you cannot administer simply normal saline because there is a free water deficit. Thus, you must administer some free water, either in the form of half or quarter normal saline. with diabetes insipidus, depending on whether essential or nephrogenic, leads to what the underlying treatment will be. As I mentioned previously, when the problem is central DI and there's simply a deficiency of vasopressin, one can give a vasopressin analog. This is specific for the renal V2 receptors, which allows for increased water reabsorption. In nephrogenic DI, however, one must treat the underlying cause. Other possibilities for treatment include salt restriction, as well as the administration of thiazide diuretics, as they block the urine diluting ability without altering the urine concentrating ability. Remember, once we said thiazide diuretics act in the distal convoluted tubule. The distal convoluted tubule is one of the diluting segments of the kidney. Therefore, blocking that activity will prevent further dilution of the urine. Let's walk through a few cases. A 35-year-old man who has felt ill for the last 3 days complains of nausea, vomiting, and diarrhea. He has had poor appetite, has had decreased PO intake. In the emergency room, his blood pressure is 85/50 with a pulse rate of 125 beats per minute. The lab studies are as follows: sodium concentration low at 123, urine concentration of sodium at 8 milliequivalents per liter, which is low, potassium concentration of 3.5 milliequivalents per liter, bicarbonate concentration of 19 milliequivalents per liter, chloride concentration of 94 milliequivalents per liter, glucose concentration of 98 milligrams per deciliter, and plasma osmolality of 255 milliosmoles per kilogram, which is also low. The two questions are, what is the cause of the patient's hyponatremia, and how would you treat this patient? Once again, the first step in classifying someone with hyponatremia is to classify whether they are truly hypoosmolar. In this case, we have a measured plasma osmolality, which confirms a low plasma osmolar state. Next is the classification of the patient's volume status. The patient's low blood pressure, tachycardia, and clinical history are all consistent with volume depletion. Thus, this must fit the category of hypovolemic hyponatremia. The treatment for hypovolemic hyponatremia is intravascular volume expansion with the administration of IV fluids. IV fluids should correct the intravascular volume status, which will then appropriately suppress ADH release. Let's walk through another case. A 68-year-old female smoker presents with 6 months of unintentional weight loss and recent onset of confusion. The patient has smoked a total of 80 pack years. Her lab work reveals the following abnormalities: plasma sodium 122, osmolality 250, urine osmolality 950. Blood pressure is normal both supine and upright. Questions are, based on the lab values, what is the most likely diagnosis, and what information do we gain from the urine osmolality? Once again, walking through this systematically, approach to the hyponatremia, we first determine the osmolar state. We again have a measured plasma osmolality, which suggests this is a true hypoosmolar state. The next is the determination of the patient's volume status. Based on the blood pressure being normal both supine and upright, this suggests that their effective circulating volume is normal. Thus, this fits in the category of euvolemic hyponatremia. As we said before, the key feature in distinguishing the underlying etiology for euvolemic hyponatremia is the urine osmolality. In someone with excessive free water intake, the urine osmolality is appropriately low. In this setting, the urine osmolality is inappropriately high. There's too much water reabsorption, and the urine is too concentrated. Therefore, this must be an inappropriate release of ADH. Given the clinical history of weight loss in a smoker, this is likely a small cell lung cancer leading to ADH release and the syndrome of inappropriate ADH release, or SIADH. The key concept in the primary disorders of ADH is that the urine osmolality will be inappropriate for the given abnormality in the serum osmolarity, meaning that in the setting of hyponatremia, the urine will be too concentrated in SIADH. Alternatively, in diabetes insipidus, the urine will be too dilute for a clinical state of hypernatremia and increased osmolality. Let's just continue with case 2. As you suspected, a chest X-ray revealed a 2.5 centimeter centrally located pulmonary nodule. This would be consistent with a small cell carcinoma of the lung, which can secrete ADH in an unregulated manner. Because of the intact renin-angiotensin-aldosterone axis, the patient remains euvolemic. How will we treat this patient? As we said, the treatment of SIADH is focused on treating the underlying cause. Nevertheless, water restriction must be a component of the patient's treatment. As we said before, hypertonic saline is reserved for acute onset of hyponatremia with severe neurologic symptoms, predominantly active seizure or impaired consciousness. This patient's mild confusion would not qualify for an indication for hypertonic saline. Let's walk through another case. LK is a 19-year-old female with no significant past medical history. Recently, she seems to be going to the bathroom frequently and has been very thirsty. She is now urinating every hour, or having polyuria, and drinking more than 5 liters of water daily, or polydipsia. She was seen by her doctor. Blood pressure was normal, heart rate was normal, and blood and urine samples were obtained. What is the differential diagnosis? The differential diagnosis of polyuria and polydipsia are primarily 3 things. One is impaired urinary concentrating ability, such as in the setting of diabetes insipidus. Another is a solute diuresis. A naturally occurring solute diuresis is in the setting of uncontrolled diabetes. This will lead to polyuria, volume depletion, ADH release, and polydipsia. The other alternative is simply primary polydipsia. If someone is drinking water excessively, they will continue to urinate frequently and attempt to continue free water excretion. This are the lab results for case number 3. Serum sodium is 147, osmolality is 301, glucose is 90. The urine osmolality is 70 milliosmoles per kilogram, and the glucose in the urine is negative. How does that change our differential diagnosis? Based on the serum glucose concentration, we can effectively rule out diabetes as a cause. Based on the elevated serum sodium concentration and a inappropriately low urine osmolality, this suggests that the primary defect is in the kidney's ability to retain water. Thus, the data is suggestive of diabetes insipidus. As we said, extremely important for the step 1 exam is to determine whether the DI is central and nephrogenic. To test that, the best method is to inject the patient with a vasopressin analog. Most commonly used is DDAVP. After DDAVP administration, we see the following. The urine osmolality goes to 500 milliosmoles per liter, and the plasma osmolality goes to 200 milliosmoles per liter. This would be an appropriate increase in urine osmolality and an appropriate increase in water reabsorption. Thus, the administration of vasopressin analog corrected the DI, suggesting this is a central DI. Further evaluation would be required to make sure that there is not a tumor or another process that has destroyed the pituitary gland. In this case, imaging failed to identify a cerebral tumor, bleed, or other mass lesion. The patient had no history of trauma. The final treatment would be continuous administration of DDAVP. So let's go through question 12. The syndrome of inappropriate antidiuretic hormone secretion, or SIADH, is caused by the excess release of ADH. Which of the following will be increased by SIADH? A. Urinary flow. B. Concentration of plasma sodium. C. Plasma oncotic pressure. D. Intracellular volume. Or E. Plasma osmolarity. The correct answer would be D. Intracellular volume. Once again, ADH release will cause increased reabsorption of water. Water will distribute evenly amongst the fluid compartments in the body, primarily in the intracellular space. Thus, SIADH will lead to hyponatremia, but also increase in intracellular volume. Question number 13. Hyponatremia with a low urine sodium is seen in which of the following conditions? A. Congestive heart failure. B. SIADH, C. Recent thiazide diuretic use, or D. Hypothyroidism? The correct answer is A. Congestive heart failure. Low urine sodium reflects the kidney sensing a low effective circulating volume. Low urinary sodium reflects an increased aldosterone activity. If you recall, increased aldosterone activity stimulates the reabsorption of sodium in the collecting duct. Thus, with increased reabsorption, the urinary sodium concentration will fall. Aldosterone release is stimulated by states of low effective circulating volume. Of the choices given, congestive heart failure is the only state of low effective circulating volume. Congestive heart failure is an extremely high renin-angiotensin-aldosterone state, which is why medications that modulate this system are key in the treatment of heart failure.
This concludes Section 13 of the Renal Physiology Review. The key points to remember from Section 13 are that derangements of plasma osmolality are reflected by changes in serum sodium concentration. Changes in serum sodium concentration reflect changes in water balance rather than sodium balance. Also, that both hyponatremia and hypernatremia clinically can be approached by first determining osmolality and secondly by determining volume status.